When a malignant mass breaches the surface of the gastric wall, it presents an immediate, complex clinical challenge. We use the term gastric carcinoma as if it refers to a single clinical entity. In practice, it is a broad umbrella label covering a highly diverse set of morphological and histological pathologies. To accurately stage and treat this malignancy, oncologists cannot rely on a single diagnostic metric. They must overlay 5 distinct classification frameworks. A single tumor must be analyzed through 4 distinct visual lenses: anatomical location, gross morphology, depth of invasion, and cytoarchitecture. Textual descriptions fail to capture the spatial reality. The exact same lesion presents completely different profiles depending on the lens applied. Independently, each framework provides an incomplete picture. Only by synthesizing all 5 can a clinical team accurately predict the tumor's behavior and determine the correct surgical pathway. The first variable is precise anatomical location, starting at the specific region connecting the esophagus to the stomach, the gastroesophageal junction. This diagram outlines the Siewert Classification, the primary topographical system used exclusively for staging tumors within this transition zone. Siewert type 1 tumors originate here, in the distal esophagus. These frequently arise from Barrett's esophagus. Dropping down, Siewert type 2 tumors are situated exactly at the true anatomical cardia. Finally, Siewert type 3 describes subcardial gastric carcinomas. These originate below the junction line and invade upward into the esophageal space. This spatial mapping dictates surgical protocols. Type 1 tumors are managed using esophageal pathways, requiring thoracic access, whereas type 3 tumors require gastric protocols, managed from within the abdomen. Anatomical topology overrides generic organ labels. The specific location along this junction determines whether a surgeon approaches the malignancy from the chest or the abdomen. Moving down into the main body of the stomach, the diagnostic focus shifts from surface topography to internal tissue depth. This cross-section shows the structural layers of the gastric wall: the inner mucosa, the submucosa directly beneath it, and the deep muscularis propria. Watch how this malignant mass penetrates the mucosa but halts its downward trajectory exactly before breaching the muscularis propria. This specific depth profile defines early gastric carcinoma, or EGC, under the Japanese classification system. The disease must be confined entirely to the mucosa or submucosal layers. Notice that this classification is based solely on vertical depth. It applies completely independently of regional lymph node status. Applying this strict depth criteria determines whether a patient is eligible for an organ-sparing endoscopic mucosal resection, or EMR. Vertical tissue penetration, rather than horizontal tumor width or nodal spread, forms the absolute boundary for identifying and managing early-stage disease. When disease progresses past those early layers, we evaluate its macroscopic shape using Borrmann's classification for advanced carcinoma. Borrmann type 1 presents as a protruding polypoid mass. This is an exophytic growth expanding outward into the stomach lumen. In Borrmann type 2, that outward mass collapses into an ulcerative lesion. It is characterized by sharp, clearly defined raised borders. Borrmann type 3 also presents as an ulcer, but the sharp borders dissolve. The malignancy blends invisibly into the surrounding healthy tissue. This infiltrative, poorly defined ulcerative pattern is the most common presentation of advanced gastric cancer worldwide. Borrmann type 4 abandons the concept of a discrete central mass entirely. It is a diffuse infiltration of the entire stomach wall. Infiltrating the tissue causes a profound physical deformation. The organ wall shrinks and thickens, creating a leather bottle appearance, known as lanitis plastica. The stomach is transformed into a rigid fibrotic tube, completely devoid of its natural elasticity. Borrmann's visual scale tracks tumor geometry, dictating whether a mass grows as a localized protrusion or invisibly destroys the structural integrity of the entire organ. To understand why tumors manifest in such drastically different macroscopic shapes, we have to look at the cellular level, using the Laurin and WHO histological classifications. The Laurin classification divides gastric cancers into 2 main pathways, starting with the intestinal type, also classified by the WHO as a tubular adenocarcinoma. Here, the cytoarchitecture relies on cohesive cells. They successfully align and bind together to form organized, ring-like glandular structures. This intestinal type is strongly associated with chronic gastritis and intestinal metaplasia, and it typically presents in older patient populations. The second pathway is the diffuse type. This features a chaotic, poorly cohesive cellular structure that completely fails to form glands. The hallmark of this diffuse pathway is a specific microscopic structure, the signet ring cell. Inside a signet ring cell, a massive intracellular mucin vacuole swells. As it expands, it completely displaces the nucleus, flattening it hard against the outer cellular membrane. This lack of cellular cohesion allows the cells to scatter. It is the exact histological mechanism that drives the aggressive, invisible tissue spread we see in the linitis plastica presentation of Borrmann type 4. Identifying a single isolated microscopic anomaly, the signet ring cell, directly predicts the macroscopic deformation of the organ. When evaluating a patient, these frameworks are not applied in isolation. They form a single, overlapping matrix. First, the spatial roles of the Siewert Classification map the tumor's coordinates at the gastroesophageal junction. Second, the strict vertical depth criteria of the Japanese classification determines if the disease is early or advanced. Third, Borrmann's macroscopic scale tracks the shift from localized ulceration to rigid wall fibrosis. Finally, the underlying histological drivers are established, contrasting cohesive glandular formations with chaotic signet ring infiltrations. True clinical mastery in oncology requires simultaneous fluency across all 5 of these matrices. Synthesizing them is the only way to accurately predict the trajectory of the disease and execute definitive surgical intervention.